And we're live. So let's talk about cannabis and healthcare. Welcome back to the Cannabis and Healthcare Webinar Summer Series. Let's talk about cannabis and healthcare. I am your host, Drudys Ledbetter. I am the founder of Mac Burnett Consulting and Project Destigmatize Healthcare, and I am honored to have you here today. Today's conversation is pretty exciting because it feels like the right continuation after last week's conversation with Dashita Dawson. This week, we're talking about the real cost of stigma, talking about work protections policy and the need for patient-centered pathways. Because in healthcare, stigma doesn't stay abstract. It shows up, and it shows up in clinical documentation. It shows up in workplace policies. We've seen that. It also shows up when patients are afraid to disclose their cannabis use because they're afraid of how they'll be received or perceived by their providers. And it shows up when healthcare professionals don't have the education or the language or the infrastructure to respond safely to cannabis patients. So this series exists to arm the healthcare leaders of today with the information that they need because medical cannabis is no longer on the periphery. We need to be able to operationalize our systems to defend our documentation. And that's why I'm trying to bring this information to your doorstep with Dr. Paulette Smith today. I want to go ahead and invite Dr. Paulette Smith to the stage. Welcome, welcome, welcome. How are you?
Greetings.
I'm going
Greetings.
to
I'm
go ahead
well.
and give you a wonderful introduction here. I am such a fan. You are an adjunct faculty professor in the University of Maryland's Medical Cannabis and Science and Therapeutic program. You're also an adjunct professor at Morgan State University School of Social Work. You've been a social worker for over 15 years, doing trauma-informed, culturally responsible, and responsive mental health care. Your work, it lives at the intersection of mental health, mindfulness, cannabis, science, racial equity, public health, healing, and healing-centered practice. Now, that is such a small intersection, but I feel like a lot of the people that are talking about cannabis and healthcare all align in that same place. They understand the healing power of the plant and they understand the need for logical, scientific, data-backed approaches and patient-centered approaches. So I appreciate that. I also want to tell you guys a little bit more because she leads initiatives like the Mindful Morgan and bringing mindfulness and wellness into HBCU spaces, and also is the founder of Paulette Simone. I appreciate that logo. It's beautiful. And Associates, and also Canna Heals, where she provides mental health services, wellness, education, and cannabis consultation to her clients. What I appreciate the most about Dr. Smith is that she understands this issue from so many angles, being a patient, an educator, a clinician, a researcher, a social worker. You bring such a unique perspective to advocacy. And you're someone who understands the real world consequences of stigma, even in your work, even in your research. So today we get to talk about what happens when patients are using cannabis therapeutically, but no one feels safe to say so because of stigma. We're going to talk about policy gaps, documentation, patient rights, and what you call patient centered pathways to medical cannabis access and what those actually look like in your practice and in your work. Dr. Paulette Smith, thank you for being here. Welcome. I am so honored to have this conversation with you. Welcome, welcome, welcome.
Thank you so much. I appreciate you having me today and bringing me on, bringing my voice to this conversation. It is such an important conversation and so needed. So, thank you for having me.
Oh my gosh, thank you for being here. And I'd love to start right at the beginning. I like to start at the beginning. I'd like to start with your story because when I heard it, I was completely blown away. What kind of brought you into the medical cannabis or cannabis altogether? And how did your background in social work kind of shape the way that you understood the plant and came to have and build your relationship with the plant? And then your experiences with stigma and patient access. Can you tell us a little bit about that?
Sure, sure. So, interestingly enough, I'm not unfamiliar with cannabis from a standpoint of it was in my community when I grew up, growing up in Harlem, New York City. I was familiar with weed, I was familiar with marijuana, I was familiar with that in my community. That wasn't something that was far away from me. And so it wasn't something that I was aware of in my home or anything that close, but it was something that I knew about through music, through culture, and such. And so when I went off to college and came to Baltimore, Maryland, I was familiar with cannabis and marijuana and weed, I went off to college and went to Morgan State University and was introduced to cannabis through culture and through community. I was familiar with knowing about having ciphers and people, smoking together and such. But it wasn't until I got sick and became ill with a stomach issue, a digestive issue later in my life, where I wasn't able to find relief, and someone exposed me to the potential for in the plant's natural inflammatory or anti-inflammatory properties, that I was introduced to cannabis, the medicinal properties of the plant. And that is where I was really, my mind was open to what it could do for me from a different standpoint from just what I understood it as from my culture and from my community. And so it was then, once I was introduced to medical cannabis in around 2018, when Maryland was being vetted for medical cannabis program, that I started to get more information about its medicinal properties. And then also I learned about how the prohibition of cannabis was started, and how access was prohibited. I was completely unaware of how cannabis was prohibited, why it was prohibited, and the fact that it was, such a crime in its existence. And so I understood that my community, from where I grew up, had been harmed. I understood that things did look different from Harlem and Manhattan downtown. I understood that my families that I grew up with were broken, and that some people had fathers, and some people's brothers were home and some weren't. But I didn't understand how that was connected to cannabis. And so in learning about the medicinal properties, and then learning firsthand, getting the plant, and then getting some plant medicine, and taking advantage of plant medicine with my own condition and experimenting, I started to desire more information, Drew. And so I went to learn more and became really engulfed in learning more, so much so that I started working at a dispensary that I started frequenting while I was a social worker in foster care, and became a bud tender, as were called, and I believe, still are called, but I like to think of them as patient advisors, and started working at a dispensary, and really engulfed myself in learning about the plant. At the dispensary at the time, you had to have a medical person on staff. And at the time, what we had was a pharmacist. She was in one of the first program that had a master's level educating people on the science of the medical of cannabis as a accredited program. So she talked to me about what this program was teaching her, and I said, "Listen, I need to know more." So I invested in going back to school and seeking out this master's program. Lo and behold, one class about the prohibition, one touch about the war on drugs. We'll go back to how I changed that trajectory on that knowledge base. But I learned about the science, I learned about the properties, I started contouring what I was taking for myself. I had to come out of being a social worker for foster care because I started to medicate with THC. And as you know, THC, the psychoactive part of the plant, that will get you in trouble when you are medicating and you have a job. When we talk about workplace protections, right? You cannot have a license in the space that I worked in and be medicating in this way. And so I had to leave that job. But at the time, I was also working as a therapist, and people were starting to come to me because they knew I was working at the dispensary and asking me, how do I navigate getting my medical cannabis card? How do I navigate getting into the dispensary and figuring out what to get while I'm in there? Because it's hard to navigate being in the dispensary. And you're my friend and I can ask you questions, or you're my therapist now and I can ask you questions. And so it just became, and then I was in the master's program because I started that. And my story just went from as patient, contouring the medicine, learning about it, then teaching people along the way how to get their medical card, turning that into an actual consultation business, and then turning my private practice into one that was really helping people understand the plant, being a therapist that was culturally available, culturally, bringing a basis of understanding of the plant and understanding that I'm not going to stigmatize you for using cannabis as a method of treatment. And people flocked to me in that way. And this was during COVID, and people needed therapy, and people were using cannabis because we were an essential business and it was open. And so it just worked. And to God be the glory that I was available, and people needed help. And so I became this person and then shifted into research therefore. So I know we'll talk more, but that's my story. And as a patient, I just continue to work through trial and error, got to the
Mhm.
right cannabinoids, got to the right place where I didn't need THC to really get me to the place where my stomach was best. I got the right diagnosis and familiarize myself with the plant. And so now I don't have any pharmaceuticals, no pharmaceuticals treat me. I have the right cannabinoids exactly, precisely so that I can take what I need and keep it moving. And I'm happy to be here. So that's
That
the
is
story.
awesome. I wish I had an audience here to clap you away. That was pretty awesome. I was blown away when you first told me your story because it was your deep curiosity that kept leading you towards more knowledge that would bring you to the data that would give you the information to do
Yeah,
your self-directed care, which kind of aligned a lot with my story. I had to do all of my own research when I came to
yeah,
cannabis. I was 32 going through postpartum in a state that didn't have access. So I had to like not only do all my research, but now I had to trust somebody to give me
right.
what they said they were going to give me without a label, without a test, not knowing if it would harm me or not. So I remember when we connected over that conversation, it was
Yeah,
really like, wow, the cost of stigma is so much deeper than we even imagine because
yeah,
of the risk of job safety. As a
sure.
licensed social worker, I'm a licensed nurse. Um, if we are patients, we are breaking the law as
Right.
patients. And and that's when we talk about the real cost of stigma from the work protection. I always we always talk about what are patients actually losing. We have so much research on stigma and what stigma does to healthcare and health outcomes. We know what patients are losing. But they're losing more when you're talking about cannabis because they're losing the ability to safely disclose a part of their behavior and their
Right,
daily routine that could either put them at risk or not at risk in a healthcare setting. So essentially, I don't feel safe to tell my doctor about this one medication, but if I don't tell my doctor, there could be a medication co-exposure that is avoided that I won't have access to that safety and that risk mitigation. If
right,
I tell my doctor and it's in my medical record and I have a work incident and they have to pull my records, I could lose my employment for having cannabis use disclosed in my medical record. I can lose my life insurance. I've had a veteran tell me I could lose my veteran benefits.
right,
Um, and the real cost of stigma is it's all the things and all the trickle down effect that happen because of the loss of safety and the loss of trust
yeah,
that you have with your healthcare provider. So your work right at this intersection, understanding those nuances, understanding that I had to give up this job I've had for years because I was no longer safe. I didn't feel safe in that
right,
job with the medication choices that I made. And I've seen nurses that can't talk about cannabis because then they'll be, exposed to random drug testing, which makes them an
right,
impaired. And and I'll be clear, nurses, if you overdose on some opioids at work, we will send you to therapy and we will maintain your licensure and we're going to just get you better and we're going to support your healing. But if
right,
you have a positive THC test, you can lose your licensure. So like work protections have to
right,
come down by like they have to kind of be embraced by policy as something that is part of like, hey, Schedule 3 medicine, we recognize this. Add this to the work protections, just like we add opioids, a pathway for whatever they do to remediate if they were impaired at work. Most people are not impaired at work that are consuming cannabis. I know because I'm a patient and I'm a nurse. So I know
yeah,
the nurse in that space. And you also probably do understand that intentional consumers are very intentional about how they use the plant. So
yes,
when we say the real cost of stigma, from your perspective, what are patients actually losing um, outside
yeah.
of the safety? Um,
Well, when we look at those, some of those workplace, thinking as I was thinking about myself in my early going, and having to leave the workplace where I was, and that was a place where I was finding, it was allowing me to get benefits. It was allowing me to get certain hours for my licensure. So when we look at these ideals that certain jobs have, you lose that. And so some of our clients, they're losing and can lose some of those experiences, or rather some of those standards that they have. And so it's not just about performance and such. Those are disciplinary actions that they can those some things are disciplinary that they can face, and then they lose some of those really ideal benefits that people need nowadays. And so we also want to think about some of those lingering perceptions that people face when they are considered, when they use medical cannabis, and they're considered someone who is using a dangerous substance, for instance, and something that doesn't have accepted use, which we know now has changed. But the stereotype, the stigma, those stigmas, they trickle down through families, they trickle down through perceptions in the way people see people and the way they treat people, right? And so sometimes it's not only just about the way that we have experiences out in the world, it's experience, or in workplaces or in systems, it's the way that we're treated. And so that's where I come in, and where I'm as a therapist, I see people and they talk to me about how they feel, and what comes about when you are stigmatized and it comes in a personalized way. And so, I think about those kinds of things. And I think about, even in the legal market where we are, with stigma, how stigma is facing people, even if, they're not seeing themselves as being able to get into legal markets because they still feel that stigma around, the cannabis, the plant. Hmm.
That
Yeah.
that is, oh my gosh. So as you're speaking, I'm thinking like from that lens, from the social work and mental health lens,
Yeah.
most mental health workers or people in that area. And I was having this conversation literally 2 days ago with a nurse practitioner who's been trying to kind of rally the psychology and the mental health department at her facility because a lot of them have their own stigma and don't feel that anyone with any mental health issues should be on any cannabis because of
Right.
the research that's been focused around harm reduction. So
Right.
for you to be in social work and mental health and have that lens, that's such a gift to the consumer that needs therapy but doesn't need the judgment, right?
Right.
Like I
Right.
need the therapy, I don't need the judgment. Like
Right.
you
And
miss
and
me
and
with that.
and it's so important that we understand that harm reduction should be on a continuum. You know, abstinence is not what harm reduction says. It's on a continuum. There's a level of harm reduction. There's ways that we can reduce harm even in our space of addiction, right? When someone is pathologized, of course you're going to find that addiction is lives there, right? Because when we look at the DSM, or when we look at books that pathologize, everyone, we had talked about this, everyone winds up with, a qualifying condition.
Correct.
But when we come from a place of trauma informed care, when we come
Mm,
from a place of understanding that, people are using cannabis for their conditions as sometimes their last chance method, meaning that they've tried everything and this is the method that works for them. And so you should try to understand that on a continuum, there's a place where there may be a reduction in harm, but abstinence is not going to be the answer. So coming from that perspective, noticing that your stigma lies in your looking for cessation, that is an important place to understand.
ooh, that is dropping the gems when you're looking for cessation. I think and I'm gonna say this because it sorry, mom. The other day, my mom looked at me and she said, "So I love the way your life has changed. I love where you are. I love your mindset. I love how calm you are and how you move with such intention. But can
Mm,
you just stop smoking weed?" And I was like,
listen.
how would I continue to be this person if I remove one of the medications that has guided me in this path away from
Right.
myself? And it's
Right.
because cessation is like the solution instead of saying, wow, you have found a way to manage and consume with intention and with dose and with product selection in a way
Right.
that you're still able to be such a productive human and such a present parent. And like instead of looking at it from that lens, and it's like the slight stigma because she's also a patient, but
Right.
she uses topicals and tinctures.
Mhm. Mhm.
I
Mhm.
do enjoy a social inhalation session. I think community
Sure.
is important to healing. I think it's part of the way that we connect in community.
Sure.
Yeah, these days I'm doing a tincture or liquid. Shout out to Levia. But essentially, I when I smoke, she just doesn't like that part of my intentional use. So like
Right.
she talks about that. And thank you for talking about like the way that professionals talk about cannabis use with patients. One of the
Yeah.
things that I learned from a researcher, we had a brunch after a meet in New England, Boston, actually,
Mhm.
and she said, I don't use the word use cannabis. Patients take cannabis the way that they take
Mhm.
other medications. And I was
Mhm.
like, that is such an important like switch there. And all of us on that panel were like, we
Yeah.
all want to switch the way that we discuss and the
I
way that
love
healthcare
that.
professionals talk about cannabis use with patients.
Yes.
Because you take Tylenol and you take
Yeah.
cannabis. So I think that we need to really normalize and start shifting the language because that's how cannabis use got stuck with cannabis with use disorders. And I'm going to
Right.
talk about we can't go down that tangent today, but use
Sure.
disorders are defined, and then you add the substance at the beginning. And if we're taking cannabis, we don't even qualify for the use disorder diagnosis, and we really start
Right.
to change the language unintentionally and intentionally. But
Right.
I'm gonna dig into something you said that we've talked about. Um,
Sure.
so how do we stop automatically pathologizing cannabis use, like, while being honest? Because I think the risk and harm reduction conversation and the intentional user conversation requires that we have language and terminology to use in our documentation. And the only language that we have automatically pathologizes the cannabis consumption as cannabis use disorder or cannabis hyperemesis syndrome, and they all have negative connotations. What is your suggestion in some of the language, and what have you seen in your practice or in your studies as some of the language that we could use to stop making it a negative pathology in the medical records as clinicians? Because I have a clinician audience, and everybody's going to be like, what can I do? And I always say, well, document it differently, talk about it differently. So I gave them a say cannabis, the patient takes cannabis. But what else can you jump in and give us some tips on how to we stop that automatic pathology that has a negative connotation in our medical records?
Yeah, so I think one of excuse me, one of the ways is by the way in which we ask questions. The way, first of all, let me back up. Being curious, right? Starting from a lens of curiosity, right? Because when we are determining and when we come from a space of all knowing, then we automatically act as if we have the answers, and we automatically start to judge and prescribe, and so we want to start from a place of curiosity. And so there's places where you can ask questions where it's more of a, how does this help you, right? How does your cannabis consumption support you, right? Or how does taking, right, if we're going to be changing our language in this way, how does taking cannabis, right, help you and support you, right? What do you look for when you are consuming,
Mm.
right? And this, the reason why you want to be from this particular lens is because it helps the person even become more
Yes.
available to their own intentionality around their consumption, right? Because I want, I'm doing a study right now, and pitch to people in Maryland who
Yes,
use
yes.
mindfulness practices and medical cannabis patients. But I'm doing the study because I'm convinced that people don't just use medical cannabis or cannabis and just go on about their business 100% of the time. I'm convinced that they use cannabis and they do something intentionally with it. They either do some kind of breathing, they do some kind of yoga, they do some kind of prayer, they do some kind of journaling, they do something, maybe they get busy, maybe they work out, they do something with it. And so I want you as a clinician and someone who is interested to ask these questions, because I want that person to be intentional in thinking about, what am I doing with my cannabis
Mhm.
consumption? Right? Because it is a plant that is useful, it's therapeutic. And so what am I doing and where am I using it and how is it helping me? And if it isn't helping me, let me get busy on finding a better way, right?
Correct.
Because it's important also that we know that there's education missing in the space. And so, yes, the endocannabinoid system, we could talk about that, and it exists, right? And so there are other ways to excite and activated, right? And so we want to be, as clinicians, aware of that. And so when you ask certain questions, that gets you in on, oh, maybe there's another way that I could get my focus going, because maybe, there aren't any strains right now in the dispensary that are working for me, and I didn't really notice that. I've just been hopping to one to the next. But since you're asking me how things are going, I notice that things aren't going so well, because I have been
Yeah.
hopping from strain to strain. Do you get where I'm coming from here?
Yes, yes. And I literally the reason I even started cannabis education programming was because I felt that bud tenders, where you said something earlier, they were like, and I wrote it down, patient advisors. And that's
Yeah.
because they have a unique opportunity to engage with someone at that point, but they don't have
Yes.
any of the education or supportive background information to be able to do that. At least I don't think so thoughtfully in any capacity, which then puts a lot of people at risk. And I'll tell you this from a story perspective. Again, I
Sure.
have a lot of nurse practitioners in the front lines who are seeing this day to day. And we have these conversations literally on a weekly basis. And we had a patient, 82-year-old patient, that was properly onboarded to cannabis consumption, had found her dose, had found her products, had found her location. And the commercialization of cannabis is impacting patient safety. She was
Yeah.
upsold to a higher concentration and dose and had an
Certainly.
unintended negative effect, and had to come
Certainly.
back and have this conversation, because sometimes that upsell is how people get incentivized as bartenders, instead of
Yep.
really keeping the holistic approach to the sales experience. We
Yeah.
launched with Project Destigmatize Healthcare last April. We launched um, uh, a national survey on the healthcare experience with cannabis consumption. And one of the things
Mm.
we asked was essentially, do you disclose? Why do you not disclose? And a lot of people just felt that they were the ones that ended up educating their provider on cannabis. And it felt like they were trying to pitch them on cannabis, because we don't have the right educational infrastructure for the frontline clinicians to have these conversations in a thoughtful way. And although you have your practice, I have my trainings, and holistic caring is training nurses all over the world. There's people
Yeah.
training everyone in different capacities. But I think policy wise, we need to start looking at what is the most basic information that people need. And I think just understanding that the endocannabinoid system exists is some of like just that will help you
Yes.
look at yourself differently, because like you said, when you ask someone, what are you getting out of this,
Yeah.
and what do you like, what do you do when you were asking that question? I am a very intentional cannabis consumer before my long distance runs. I run marathons,
Yeah.
and what I get out of it is I feel the complete anti-inflammatory effects. So I like a higher dose CBD the day before a big race. In the
Yeah.
morning of, I need that sativa focus so that I don't harm myself and I can listen to my body. So like when you were
Sure.
saying that, I know that I could answer that question because I've had to test it. And
Right.
now and that brings me to where I kind of want to land with this conversation as we're closing out. I wanted us to kind of daydream about the most comprehensive onboarding we can think for a new cannabis consumer. Like, what should it include? But I also wanted to bring it from the perspective of that awareness that you bring to them to make them an intentional consumer. And like, what is it? What does onboarding require if we're not even disclosing it? How do we tease the conversation out, and then how do we transition to being clinically appropriate and unbiased in the way that we ask questions to help onboard a customer? I know you teach people how to consume intentionally. I know you also have that master's in cannabis science and therapeutics that gives you that unique perspective of how to take these cannabinoids on, and what enzymes are being impacted, and the pathophysiology of how this medication is working with other medications in your body. From that perspective, I guess my where I want to kind of end and daydream is, what would a patient-centered onboarding pathway to medical cannabis look like? If education and work protections, documentation, public health. We're all built into the process from the beginning. What would that look like ideally, so
Yeah.
that there is no bias? And I kind of want you to like build the scaffolding, and I'll jump in when you
Mm,
invite me to build some like
yeah.
the clinical operations piece. But what, because I know we've talked about this. I had to onboard myself. Cannabis is a very self-directed, um,
Yes.
therapeutic interaction. You have to, it's
Mhm.
individual, and you
Yeah.
need to have autonomy. So like some people need support because of their addiction history, and some people need support because they don't have information or knowledge, or they have a lot of other medications and other comorbidities that are involved. But
Absolutely.
what would how do we get a patient safely onboarded to medical cannabis? Like if we could dream up the perfect way to do it.
So, so ideal. We would want to obviously assess, right?
Yes.
We want a comprehensive assessment, right? We want to make sure that we're recommending, or in our new space prescribing, right? We have our schedule 3 coming, right? Or now, right?
Yeah, now.
Right
Now.
now, right? Building the plane as we fly it. We want to assess, do a comprehensive assessment, screen for potential risk, make sure that there's, the right therapies in place, understand what the needs are. As a social worker, I'm always thinking about a needs assessment, making sure that we have a comprehensive understanding of what is needed, and so we can put the right things in place. Is that what we're speaking about here? Is
Yes,
that what we're looking
yes.
for?
Just looking
Yeah.
at the
So
scaffolding, like what do I, and that's because I wrote about a
yeah,
lot of these systems in that book, right? So
yeah,
I'm,
yeah,
I'm
yeah.
gonna plug my book a little bit. Healthcare
I
Cannot
love
Manage
that.
What It
I love
Cannot
that.
See. It starts shipping August 2026. We're actually having
And
these
I can't wait for
conversations
that.
because this information is available in the book, but I think it should be available sooner and earlier. Like
Right,
I almost didn't wait for it to print to start
right.
letting clinicians know that, like, because Schedule 3 is here now. Like
It's
uh,
now.
all
It's
those
exactly
hearings are for non-medical cannabis. Medical
right.
cannabis, if you have a patient who
It's
walks in
now.
from your state program with a medical card and cannabis in their pocket, you have to know how to handle it. You have to know how to
Exactly.
document it. You have to know how to deal with it. You have to make sure that there's no adverse drug events happening at your facility. It is a
Exactly.
medicine, and we don't have the infrastructure today. And I
Right.
think that
So
that's where
I
that
was going to
part.
say that's my second point. You, after the assess, we have to educate.
Yeah,
We have to get you and me and the other educators in the spaces to put in the faces of the people who are going to be with people that are facing and using the plant, and who are wanting to use the plant. Education around the endocannabinoid system, education around how this plant works, education around documentation. We need to have the cultural understanding. We need to have access and education in that space. That's the next scaffold out, I think, in an ideal space,
yeah.
and then I want to bring you in because, for me, the education, the research, obviously I'm coming to research because we need the research and we need representation in that research.
Yes.
So, I'm coming to you for what's needed in that documentation and education
Well,
space.
you were
Yes.
talking about it, that assessment. So I answer every problem, and I solve every problem with a five-step framework. Rapid: recognize, assess, process what's available to you, and plan. Implement and ignite your own fire. So get yourself fired up and get your implementation together and defined,
Yes.
and then deploy or
Yes.
decide. So you basically go through this process. And for me, yes, recognizing is recognizing we have a problem. So this conversation, recognizing that cannabis is here and we have to do something about it. And I think
Hmm.
the assessment needs to include like intake language. The education needs to include bias and cultural competent training education, because
Yes.
a lot of people are still going to inject their own personal ideas. And
Hmm.
the way that I want to lean into some of the what you shared about how you changed the program at the University of Maryland. I want you to tell us a little bit about that as well, because when you're educating scientists, and Mayabi said this the other day, Dr. Mayabi, first shout out to her too, at the research conference, and she said we so lock in on the science, we forget that there's a human factor, that there's still people in jail for this plant, that there was an entire movement to criminalize blackness
Yeah.
around this plant, that this is why it became inaccessible as medicine to us, and that harm alone is a health equity harm. And I think that we don't talk about
And a
that part
public
in
health
science
issue.
and research. We train scientists, because when I said I wanted to train clinicians about the endocannabinoid system in nursing, everybody's hell bent with it. I have to sneak in the slides about the harm that the war has done on health equity, even though
Mm,
health equity is a priority in our state, because the minute
mhm.
you bring that in, everybody's like, wait a minute. And I'm like, no, this plant was specifically criminalized to attack blackness and be black in
That's
America.
right.
And people are
Right.
still in jail for crimes associated that are nonviolent to this plant while we're out here eating it up. So I think it's important that we always say in these scientific spaces, free the plant, free the people, deschedule. Like, we shouldn't even
Please,
be having to plan, right? This is
please.
very chaotic for me, because we're having to plan, because this is
Right.
where we're at. But the truth is,
Exactly.
the plan shouldn't be scheduled, period, so that we could intentionally bring it into healthcare without having to force it into an FDA pathway that will dishonor the plant and turn it into a pill, and
Yeah,
take away its true medicinal powers. So I'm we have to remember that there's a social justice movement and an equity justice underneath all the science. And I
yeah,
think that our representation in this space always brings it to the forefront, because we're saying yes, and let's not forget that people are still in jail for cannabis, and that's
absolutely.
not okay. So yes,
Absolutely.
jump right in. The
No,
research, we're both doing
it,
research.
it is absolutely, I in the program, I'll just shift that the idea that we're teaching scientists, in this program that I came through, it was a blip about the idea of how cannabis was prohibited and how, what happened with the war on drug, or what's happening with the war on drugs, and who is harmed on the back of this prohibition, and even to today. And so I said, while I was in the program, I wrote to the director and I said to her, and we actually wrote a paper together on the back end of me coming out of the program. But I wrote to her and I said, wait a minute, I learned not enough about this, and I had to do my own research, and I did a great deal of learning about cannabis science and therapeutics. Thank you. That's the name of the program, but it's not enough to understand what happened and what's still happening in this, environment and this industry. And so she said, well, if you can create a course rather, then I want to see it. And she held me to it. And I started my doctorate program the day after I graduated from that master's program. And I started my doctorate with the eye on creating a course for for that master's program. I started TAing in that master's program, and I started grading, and I started creating the course in the doctoral program. By the time I finished my doctoral program, for my capstone, I had to create a 14-week course, which is a 14-week course for social workers. That was my capstone. But for my master's program, I created an 8-week course around social equity and regulations. And it is actually, and I'm proud to say, starting today, we started the second iteration of the course, and it just launched June 1st, which this morning I hit live, and the students just started, and we are running that course. And so it is an 8-week course that teaches about social equity in this space. I have the social equity director from the Maryland Social Equity Department here. She did an interview. We talked to the one of the social equity pioneers in New Jersey. He did an interview for the students. And so they're going to get, and the first iteration of the course, they loved it. This iteration of students, I hope they love it as well. It's called social equity in the cannabis industry, looking at pathways forward. So, we're trying here. I'm doing the best I can, and stigma be damned.
That stigma be damned. That is, I stigma be damned is the perfect way to close this out. Stigma be damned. I always like to let people know how to find. First of all, it's mind blown. This conversation has been wild. So how can people find you? I'm going to give you the stage for a minute. I'm going to just back off and you talk to them, tell them how to find you.
Oh, sure. Well, thank you for the stage. I am on LinkedIn at Paulette Simone. I am on Instagram at canna.heals, my business. I can be found on the web at paulettesimone.com. I have a presence there on Instagram where I share information about social equity, about mindfulness, about cannabis wellness, and all things. So join me there. And if you're interested in that master's program or that course, that is at University of Maryland. Or if you're a social worker, I'm at Morgan State University. Yes.
I am back.
Yes.
I am back. That was awesome. Thank you for taking the stage and sharing your information. I have so many thoughts, so many ideas. I want to thank you. This conversation was everything. Like, I knew we were going to hit some things. I appreciate that we didn't just talk about cannabis,
Sure.
because sometimes we talked about people, we talked about the stories, we talk about the patients, navigating care, like with the stigma. That's really hard. I faced that head on. We talked about our workers who are trying to protect their health and like their jobs. They don't want to risk living without their careers that they work so hard for, and talking about clinicians being informed and how to educate them, how to educate social workers. You're educating everybody. I appreciate that. And I think the most important thing that we've talked about is what happens when we replace judgment with curiosity. That was such a nugget. If we really start to lead with curiosity, we can get rid of stigma in a lot of places, because that stigma is causing delayed care, underreporting, mistrust, things that we don't need to face. And patients are navigating all of this alone. And I see them all as missed opportunities for healing. And I think that the way that we build is to build a better language and policy and protections. I want to encourage you to keep building better education, and keep daydreaming with me to build safer pathways for patients to access medical cannabis with dignity and with support and with respect. And that these conversations move us beyond like practical science, but really to like operationalize and change healthcare and systems and workplaces and academic institutions. So thank you for your leadership, Dr. Paulette. Thank you for your scholarship. Thank you for your research. Thank you for the work that you continue to do to make this space more informed, more human, more compassionate, more equitable. And thank you to everyone who's joined us today for Let's Talk About Cannabis and Healthcare, all summer long, session 2. What an honor. What an awesome way to keep this conversation going. I want us to continue to have these conversations because the truth is healthcare cannot manage what it cannot see. And until we start to be willing to see things clearly, we're not going to be able to change the situation in healthcare. So thank you, and I'll see you next episode. Thank you. Thank you.
Thank you.